Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a discussion on the instruments that we are using in tonsillectomy and adenoidectomy. We'll talk about how to identify the instrument, what does it look like, and what are its uses. You can also now purchase my notes. I have added links in the description. Okay, so our first instrument over here is the Boyle and Davis's mouth gag. This is the first instrument that you require to perform both of these surgeries. Now, this is a very important point to remember here is that this is a self-retaining mouth gag. We have two parts over here. The blade that you are seeing here, this is the Boyle's blade. Usually there are various sizes of the blade that we choose depending on the age of the patient. And the second part is this is the Davis's gag. Now these two together, they are put like this. If you look at the second image over here, this is how they are put together. And once it is brought to a closed position, so the position that you're seeing over here, this is a closed position. Then what you do is you insert a tongue depressor, insert the tongue depressor into the mouth after you depress the lower jaw. And then slowly, this is the ratchet over here. This you press on this part of the instrument that you're seeing here, this region. As you press this, you slowly start opening the mouth gag. So you go in this direction. And as you open it gradually and you find that you have reached adequate exposure of the oral cavity, then this ratchet over here will make it self-retaining. So this is what Boyle and Davis's mouth gag is. Important to remember that this is a self-retaining mouth gag. Now, what are the uses of this instrument? So, the first use over here, as we know, is already, which is tonsillectomy. The dissection and snare method in tonsillectomy is where we use this mouth gag. Second is we use it for adenoidectomy as well. But other than this, there are numerous other surgeries as well where we can use this, which involves the oral cavity and the oropharynx, even the nasopharynx sometimes, even for palatal surgeries, maybe for cleft palate repair or submucous cleft, and even in surgeries in craniovertebral anomalies. So these are all the uses of this Boyle and Davis's mouth gag other than tonsillectomy and adenoidectomy. Now, sometimes you can be asked, what is the advantage of this instrument? So, our first advantage is, as I've mentioned, this is a self retaining mouth gag. This does not require the help of an assistant. Like, nobody needs to hold it. This will just, once you have locked the mouth gag in place, this will maintain the adequate exposure of the oral cavity by itself. So it does not require, you can do it yourself. You do not need another assistant to help you with this instrument. And it also gives a very good exposure of the tonsillar fossa. But this also has some disadvantages. There are some risks of injury that can happen if you're not careful while you're putting in this gag. Amongst this, the first thing that will happen if you look at this region, this part is fits into the region of the upper incisor of the patient. So it is important to remember if you're not careful while putting in this mouth gag, you can end up in causing an injury to the incisor tooth. So sometimes a lot of patient ends up leading to loss of the tooth, the incisor tooth on the upper jaw. So you have to be very careful. You put a gauge piece over underneath this as you introduce it into the mouth. Other than injury to the incisor tooth, even as you are manipulating to try to put this gag in, you can end up causing injury to the lip or the palate or even the angle of the mouth. So these are the disadvantages that you have to be careful about when you are putting in this mouth gag. Moving on to our next instrument, which is the Draffin's bipods and the Magauren plate. So these two are our bipods and this is our Magauren plate. So now that that we have seen that we have introduced the Boyle and Davis's mouth gag, we also have to hold it in position, right? So these three things will come in play over here. So we can see that these Draffin's bipods that we are seeing, this is a bipod metallic stand. So we have two stands over here, and you can see there are multiple rings in these stands. And this is the Magauren's plate. The lower end of the Draffin's bipods goes into this Magauren's plate. So what you do is the position of the patient. If you look here, this is how we are going to put in these two instruments. So this is our mouth gag and the Boyle and Davis's mouth gag. So we put the Draffin's bipods at the edge of it, and then we try to maintain the extension of the neck of the patient who's in supine position by fixing it on the Magauren plate. We see which one of these holes is required to get adequate exposure for you, and that's how we fix the Draffin's bipods into the Magauren plate. Now the use of this helps in fixing the mouth gag for any of the surgeries that we just discussed, any oral surgery, any oropharyngeal surgery, or any nasopharyngeal surgeries. This helps you in fixing up the gag and giving you adequate mouth exposure. So this was about Draffin's bipods and Magauren plate. Next, we move on to Clair Thomson Adenoid curette. So, if we are performing an adenoidectomy and a tonsillectomy together in a patient at the same time, the first thing that you need to do is to perform adenoidectomy, and then we move on to do tonsillectomy. So, the major instrument that we require here is the Clair Thomson Adenoid curette. Now, this comes in two parts, two types. One is with a cage, and the other one is without a cage. So this is our primary instrument that is used to remove the adenoid. What do we do? So you hold this adenoid curette in a dagger holding fashion, and then you slowly introduce into the oral cavity, go beyond the soft palate, and make sure not to touch any of the structures as you're doing this. And then once you're in the nasopharynx, you slowly move your hand in a very swinging motion. And this motion is done along the midline in the posterior nasopharyngeal wall. As you do that, in the swinging motion, you curette out the adenoid. So that is how we perform adenoidectomy with this instrument. Now I mentioned that it has two types. One is with cage and one is without cage. So this front portion that you're seeing over here, this is the caged portion. So if this is present, this is a with cage, and if this part is not present, then it is without cage. Now what is the importance of having two variations of the same instrument? So if you when you first do adenoidectomy, you do it with the cage. The purpose of this cage is that it prevents any kind of slipping of the adenoid tissue that you are curating out. So if it's basically preventing any slipping of the tissue and aspiration into the lower respiratory tract. Second, it is helping you in completely removing the adenoid properly. So this is the use of the cage portion. Now, after you have done curating with the cage, in the last time you do it without the cage. What is the purpose of this? If there are any remnant of the adenoid tissue left behind, especially around the eustachian tube, which lies in the lateral wall of the nasopharynx, and even sometimes tubal tonsil, this without cage instrument helps you in removing it without causing any injury. So we do not want to, if we are using the caged one in this region of the eustachian tube opening, we may end up causing injury to the eustachian tube opening. So therefore, we'll use without cage over here so as to remove any remnant and sometimes even tubal tonsil. So that is the importance of having two variations of this with cage and without cage. So as we discussed, the primary use over here is to perform adenoidectomy. And there are some precautions that you should take while you're performing adenoidectomy. First is that, so we know that the patient's neck is fixed in an extended state. So when you're doing this adenoidectomy, you have to flex the neck of the patient as you're doing the swinging motion with your hand and trying to curette out the adenoidectomy. Why? This is done so as to avoid any kind of subluxation of the atlanto-occipital joint. So if you don't do that, there is a risk of atlanto-occipital joint subluxation. Second precaution that we need to remember while we are performing adenoidectomy using this curette is before you introduce the curette, we first need to digitally palpate the adenoid. So you'll introduce your finger, you'll try to palpate the adenoids, and with your palpating finger, you'll try to move the adenoid to the middle of the midline of the body. Sometimes it can lie on the lateral wall, like it can be pushed to the lateral wall. So you try to bring it to the midline before you introduce the curette over here. So this is the use of Clair Thomson Adenoid curette with and without cage. So now adenoidectomy is done. Now we move on to discussing the tonsillectomy instruments. So our first instrument that you'll require over here is the Denis Browne tonsil holding forceps. So if you see that here, this is a very angular instrument. So it goes at an angle like this. And this instrument has a lot of resemblance to Lux forceps. However, at the same time, it has differences as well. So the differences here is that you can see that this is the upper blade and this is the lower blade. The upper blade kind of fits into the lower blade. It is not also the edges of this jaw that we are seeing over here, they are not sharp at all. Whereas for Lux forceps, the jaws are very sharp. They are meant to take maybe for example biopsy. But for here, the jaws are not sharp at all. They are atraumatic. And that is why we are using this forceps to hold the tonsil. So the primary use of this Denis Browne tonsil holding forceps is to hold the tonsil and then pull them medially while we are performing the dissection and snare method of tonsillectomy. And because the jaws are not sharp over here, it causes very little tissue trauma while you're holding the tonsil. So this is our first instrument that you have used when we do tonsillectomy. Now that as we hold the tonsil, our next step is to incise the mucosa between the tonsil and the anterior pillar. So the instrument that will be used over here is known as the Waugh's tonsil dissecting forceps. Now if we look at the edge over here, this part has an edge that looks like this. So this is how the tip looks like. And this tip fits into the other side of the tip. And this is a tissue forceps which is used for dissecting and grasping. And this forceps also has a spring joint. Now the use of this is to, if this is the tonsillar pillar and this is the tonsil, we use the Denis Browne forceps to hold the tonsil and then we pull the tonsil medially, and then in this region in between the anterior pillar and the mucosa of the tonsil, that we give an incision with this Waugh's tonsillar dissecting forceps and we drag it down from the upper pull towards the lower pull. So this is our primary use of using Waugh's tonsil dissecting forceps. Other than this, another purpose that we can use it for is for catching any bleeding points, or if we have found a bleeding point, to use the forceps to hold a swab and inserting it into the bleeding area. So this is about Waugh's tonsil dissecting forceps. Next, we have the Mollison tonsillar dissector and pillar retractor. So this instrument is a double-ended instrument. You can see both the ends of this instrument look very different. One end, this end, we are seeing that this end is very flat and rounded. So this part is the dissector end. And the other end of the instrument, we can see that this is a broader side and it is blunt and it is slightly curved over here. So this is the retractor end of the instrument. So this instrument has dual purposes over here. So the use of this instrument is, with this dissector part of the instrument, it is used for blunt dissection of the tonsil from the tonsillar fossa after you have given the incision with the Waugh's tonsillar forceps. And this we use this end of the instrument to dissect the tonsil away from the tonsillar fossa right up to the lower pole. And therefore, we are basically defining the plane between the tonsil and the superior constrictor muscle with this end of the instrument. Now, if we look at the retractor end of the instrument, the purpose of this side of the instrument is to retract the anterior pillar. Why do we need to retract the anterior pillar? If, first of all, after we have removed the tonsil, we can use it to look for bleeding points in the tonsillar fossa. We can also use this to check for any tonsillar tags that might have been left in the tonsillar fossa. And other than this, also we look for any retained swab or gauge pieces that we may have left behind when we were trying to control the bleeding. So these are the uses of the dissector end and the retractor end of the instrument. Our next instrument is the Eves tonsillar snare. Now, if we look at this instrument, how are we going to describe it? So you can see that this is a very long cylindrical instrument. It has a handle, it has finger rings, it has a sliding mechanism over here, and there is also a wire or a snare at the distal end. This snare is usually of stainless steel wire. And important to remember, some Viva question is that this is 3 inches long and it has a thickness of 28 gauge. So these are some Viva questions that you need to know. Now, what is the use of this instrument? We use this instrument to remove the tonsil by snaring the lower pole after we have performed dissection towards the lower pole. Now, by snaring the tonsil, what is done is we achieve cutting and crushing of the lower pole. Now, why is this important? Why can't we just cut off the lower pole of the tonsil? So this instrument, it works on the principle of crushing and cutting the tonsillar pedicle. So we are snaring the lower pole because at the lower pole, a lot of tonsillar blood vessels enter and leave. So when we are crushing here, the thing that is released over here is known as thromboplastin. Now, what does thromboplastin do? Thromboplastin causes vasoconstriction and platelet aggregation, and that is how we attain hemostasis over here. Therefore, this instrument is a cutting and a hemostatic instrument. So it is removing the tonsil, whereas at the same time minimizing the bleeding because of its crushing action. Now, how do we use this instrument? It's important to know that as well. So what we'll do is we'll be inserting our index and middle finger into the two rings that we are seeing over here, and the thumb will be placed inside this ring. So we have our index finger here, middle finger here, and thumb is placed in this ring. Now, this loop of wire, this snare is opened up fully. Once you open up fully, we'll introduce the tonsil holding forceps through it. Then we'll use the tonsil holding forceps to grasp the tonsil and pull it medially. And then we'll push out this snare towards the tonsil at the lower pole. Now, once it has reached the lower pole, the snare wire loop is withdrawn into the tube of the snare by, we'll basically be pushing this. We'll take out our thumb from this ring and we'll place our thumb over here and we'll push it to do this sliding motion with the thumb, and then this wire will close down and it will excise out the tonsil at the lower pole. So this is how we use the Eves tonsillar snare. Important to remember is that this releases thromboplastin, and that is why we use this. Thromboplastin will be released, leading to platelet aggregation, causing hemostasis in the tonsillar fossa. So another question that comes in over here is, in every surgery, we have some amount of normal blood loss. So what is the normal blood loss in case of tonsillectomy? So normal blood loss is 50 to 70 ml which is normal. Anything more than this is not normal, and that will come under the complication of hemorrhage. I have a separate video on post-tonsillectomy hemorrhage. You can check out what is the difference between primary, reactionary, and secondary hemorrhage, what are the difference in causes in all of them, and how do we treat each one of those causes. Next, moving on to our next instrument, which is the Negus Tonsil Artery forceps. Now, if you look at this is actually a hemostatic forceps. What do you mean by hemostatic forceps? It is basically used to clamp bleeding vessels. How do we describe this instrument? This is a long, slender artery forceps which has curved jaws, and there are fine transverse serrations along the inner surface of these jaws so as to prevent any kind of slippage. And the end that we are seeing over here, these are very blunt ends. It does not have any teeth. This prevents any kind of tissue trauma. So what do we use this forceps for? So our primary purpose for using this forceps is to achieve hemostasis in case of tonsillectomy. So if after you have removed the tonsil, if we are seeing any bleeding points which are not getting controlled by pressure with a gauge, in that case we are using this forceps to clamp that bleeding point in the tonsillar fossa. And after we have clamped it, we hold the vessel securely over there, and then we use a Negus's ligature slipper to pass the ligature and then tie the bleeding point over there. That is the purpose of using this instrument. So that brings us to our next instrument, which is the Negus ligature slipper and knot tire. Now, if we had to describe this instrument, what does this look like? This looks like this long, slender, rod-like instrument, which has a very flat handle and a forked distal end. It looks like the ends of a fork. This end, it is forming a small groove in between these two forks. That groove is used to hold and guide a ligature around the tip of the artery forceps. So the primary use of this instrument is to slip the ligature over the tip of the Negus Tonsil Artery forceps while we are trying to ligate blood vessels during tonsillectomy. How do we use it? So first we have to apply the Negus Tonsil Artery forceps on the bleeding vessel. Once we have done that, we'll take a silk ligature, we'll prepare it, and we'll loop it around the forked end of the Negus ligature slipper. Now this forked end which is carrying the ligature is now passed behind the tip of the Negus artery forceps so that the loop of the silk passes around the jaws of the forceps and the vessel lying underneath it. Now once the loop is slipped off from the fork, we pull up so that the ligature encircles the vessel completely. And now using the same instrument over here, the ends of the ligature are tightened around the vessel and hemostasis is secured. Once we are sure that the knot has been tied properly, we release the Negus artery forceps and check for bleeding. So that is how we do ligation using the Negus ligature slipper and knot tire and the Negus artery forceps. Our last instrument for the day is Yankauer suction cannula. Now what is this instrument? So we can see that this is a very curved metal tube. It has a bulbous handle over here. It has a terminal suction tip which has very rounded edges and multiple side holes, and it has a proximal connector here where we connect the suction tubing. So important to know is the tip that you're seeing over here, it is rounded. It has one single central opening and multiple lateral holes. The purpose of this being it prevents any trauma and blockage during the time of suction. Now, what is the purpose of this cannula? It is helping you in suctioning out oropharyngeal secretion or any blood during surgeries like tonsillectomy, adenoidectomy, palatal surgeries, and even microlaryngeal or airway surgeries. Now, there are certain advantages of this instrument. Why can't we just use any cannula? We use this cannula because, first of all, this tip that we are seeing over here, it is rounded and it is atraumatic. So it prevents any injury to the mucosa or the tonsillar pillar. Second is the curve of this instrument. Because of the curve of this instrument, we are able to suck out all the secretions without obstructing any view. Third is the length of this instrument. Because this instrument is very long and it has a large handle, you can use this instrument to perform suction from a distance. And the operating field, therefore, is not getting obstructed by the hand of the surgeon because of the long length of the tube. Lastly, the tip has multiple holes over there so as to prevent any blockage of the suction. So even if one opening gets blocked, all the other openings will function. That is the beauty of this cannula. So that finishes our discussion on all the instruments that are used for adenoidectomy and tonsillectomy. If you have any further question on this, you can note them down in the comment section and I'll get back to you.